Hey guys, hope the studying is going well. The purpose of this talk is to just provide an overview of common lower extremity injuries in the young athlete. I have no disclosures related to it. Here's the outline for what we'll discuss. It's mostly, as you see, hip and knee, although I would argue that many of the concepts we'll review will be applicable to injuries of the ankle, elbow, and shoulder. First, I wanted to start by reviewing some common lower extremity injury risk factors for young athletes. One of them is the relative weakness of the growth plate. We know that rapid growth and cellular turnover make the growth plate the weak link in the chain and the area most at risk for injury. In addition to the presence of an open growth plate, the period of peak growth velocity is a time when kids are particularly prone to injury. During this time, they experience a relative tightening of the joint spanning major muscle groups, which in turn increases stress across joints. And so this is a time where it is not uncommon to have kids present with patellofemoral syndrome or back pain. And then additionally, kids actually go through an awkward stage, so there are changes in balance and proprioception as kids grow into their new bodies. That's what this picture is demonstrating, and because of this awkward phase, we actually see them experience more falls and so traumatic injuries as a result. Looking specifically at the hip, I wanted to start with apophyseal avulsion fractures, which is a quintessential pediatric injury. So this is characterized by the acute onset of localized pain and inability to bear weight that happens during athletic activity. Primarily, it occurs in adolescents aged 11 to 16. It's more common in males and especially in track and field, especially in the jumpers and sprinters, as well as soccer players. It results from a forceful contraction of the involved muscle that occurs during sprinting, jumping, or kicking, and kids may have a prodrome of symptoms, which we call apophysitis, prior to the acute avulsion event. On exam, they'll probably limp if they'll walk at all. You'll find that they have focal tenderness when you palpate the area that is affected, and you may see swelling and bruising, although you may not. They'll have pain with passive stretch and active contraction of the affected muscle, and so, for example, an AIIS avulsion fracture, which involves the rectus, would result in pain with passive hip extension and active hip flexion. This is probably a high-yield slide for this injury, and this just demonstrates some of the most common sites for apophyseal avulsion fracture to occur in kids. The most common you see here is the ischial tuberosity in the hamstrings. The least common is probably the iliac crest, and I'll let you just go through that. This is something probably just to memorize. Treatment is typically non-operative, so it's crutches, activity modification, rehabilitation, and kids are generally out for somewhere between 3 and 6 weeks, probably back to full sprinting somewhere between 6 and 8. Operative repair is rarely indicated. One indication, however, for operative repair would be if there's more than 2 centimeters of displacement, and this is depicted here. And you can see the surgery that was done to address that here. For the ischial tuberosity, this is because of the proximity of the sciatic nerve. Other things you can see, in addition to just nerve irritation, is that sometimes these will heal with really a robust cloud of new bone that can mimic a tumor, but it can also entrap the sciatic nerve and scar tissue, or the AIIS avulsion fracture actually can cause a subspine impingement, so an extra-articular type of femoroacetabular impingement if it heals in a malunited position. Okay. So snapping hip syndrome, there's 3 primary kinds to know about. One is internal, coxasultans interna. This is resulting from the iliopsoas and typically snapping over the iliopectineal eminence. External, which is what is depicted here, coxasultans externa, is the iliotibial band snapping over the greater trochanter. Kids can do this for you in the office. They can oftentimes recreate it. It can look very violent, and it's typically some form of active hip flexion and external rotation followed by extension and adduction. We also sometimes call an interarticular problem like a loose body snapping hip, although as you know, this is really a different entity. This is treated, so kids will come in with localized hip pain, maybe a reproducible snap or click. This may be chronic or overuse, especially in athletes such as your dancers. Treatment is typically non-operative, Rice, NSAIDs, PT, avoiding the activity that worsens the symptom. Sometimes we'll do a corticosteroid injection. That's what this picture is depicting. This is an intra-sheath injection for the iliopsoas tendon. This was done under fluoroscopic guidance with dye, although you could probably at this point do that in the office under ultrasound guidance. And then in truly refractory cases, we can also do a surgical release. We'll talk briefly about FAI. So this is an abnormal bony abutment between the acetabulum and the proximal femur. There are three major types. The first is CAM or femoral sided, and this is the result of direct contact between the bump that you see usually on the anterosuperior aspect of the proximal femur, and then having this abut the anterosuperior acetabulum, and so you can see cartilage loss and associated labral tears. Pincer type impingement is acetabular sided. This is usually over coverage of the cup, making contact with the normal femur. And then we also see mixed impingement. Typically we say that the CAM impingement is more likely to occur in males, pincer in females, although actually a mixed picture is probably the most common and occurs in both. Kids with FAI may present with activity-related deep groin pain, or sometimes pain actually just with sitting for a long time. We see it especially in repetitive motion sports like ballet, soccer, or ice hockey. They'll give you the C sign, so holding their hand in a C and holding the side of their hip with that. They may have associated clicking or catching, which could be an unstable labral tear, a loose body, or the coxa saltans interna that we just talked about. The impingement test is typically restricted passive internal rotation, flexion, and then this also causes pain. And the whole hip, in fact, may light up, everything from the SI joint to the iliopsoas tendon and sort of everything in between. Typically, we evaluate this with radiographs, so an AP pelvis. And then a done lateral is also typically done. We can measure the alpha angle, and this is a moving target, but typically we say greater than 50 or 55 degrees. It is consistent with CAM impingement. We look for things like the crossover sign or retroversion to look for dysplasia. MRI is a gold standard. I know here we typically don't do an arthrogram anymore because our MRIs have become so good, although many places an MRI arthrogram in which the dye is injected into the hip joint under either ultrasound or fluoroscopic guidance. It was considered the gold standard for evaluation of a labral tear. And then oftentimes additionally we'll do a CAT scan to look at bony morphology and to better evaluate the version. And this picture is demonstrating for you how an alpha angle is measured. FAI may be treated non-surgically initially, especially in children with NSAIDs activity modification PT. An important part of PT is pelvic tilt to unload the anterior hip. Again, a corticosteroid injection can be done, and this may be either diagnostic and or therapeutic. And there was a recent study actually out of Rady Children's in San Diego looking at non-operative treatment for FAI in kids and finding that in fact in a significant proportion of them this was successful in returning them to sport. However, when non-surgical measures are not effective, then surgical treatment does become the standard of care, and so this may be done arthroscopically. You're not going to do an arthroscopic treatment for FAI if it's resulting from dysplasia, but if the hip is otherwise normal morphologically, then your surgery is going to be tailored to the pathology that is present, be this a labral injury, and so if you do have a labral injury, you're going to debride versus repair. We know that repair has superior outcomes. Likely a femoral osteoplasty as well. We also know if you simply address the labrum but you have a CAM lesion, then the labral injury is likely to recur, so you're going to do those things in combination. And then as needed, acetabular osteoplasty or rim trim, and then chondroplasty as well. And lastly, surgical hip dislocation may be considered, especially for patients who do have some component of dysplasia. Labral tears can occur in isolation in the absence of any bony bony abnormalities. And these can be oftentimes will present acutely. So a kid will come in with complaints of clicking, popping, or pain in the hip. Again, oftentimes this is in dancers or gymnasts. I've seen it in figure skaters as well. Your exam will be your fader test, the flexion, adduction, internal rotation, also known as the impingement test. But this is actually going to allow you to catch the unstable labrum. It's sort of analogous to a McMurray's, and then actually the scour sign in which you try to entrap it is more like the McMurray's. An MRI arthrogram again is diagnostic. These can heal, especially in kids, without surgery, and so you may do a course of protected weight-bearing activity modification followed by physical therapy. Still not helpful, you can do a corticosteroid injection, and then again in refractory cases you can do an arthroscopic labral repair, and again repairs have superior outcomes to debridement. Even though this is not typically a sports injury, I always like to mention it because I do think this probably is a more highly testable thing, and that's the slipped capital femoral epiphysis. This is one of those that you never want it to have seen you and you didn't see it. So this is something that you'll hear about from one of the other peds guys too, but occurs typically in kids age 10 to 15, oftentimes around the time of the pubertal growth spurt. It may be bilateral in up to 50% of the cases. Occasionally this occurs simultaneously. More commonly it occurs sequentially. It's more common in males than females. Obesity is a primary risk factor for SCFE. In fact, half of kids who present with a SCFE are at greater than 95th percentile in terms of their weight. You always want to think about an endocrinopathy, especially in kids who are more of an atypical presentation. Hypothyroidism is the most common. And then the thing I always like to highlight is that, in fact, 15% of patients with a SCFE will only come in with a history of knee pain. And so if you only examine the knee, you may miss this, and I have seen this happen. So always remember they're connected, and never put off a SCFE as an anterior knee pain or patellar syndrome. On exam, a kid with a SCFE may have a limb that is shortened, abducted, and externally rotated, similar to a femoral neck fracture. You'll see obligate external rotation as you bring the hip into flexion, and limited internal rotation, especially when you compare it to their unaffected side. An unstable SCFE patient will not really allow any passive motion. You may, if it's a stable situation, you may see a penguin walk. So that's the obligate external rotation. This may be asymmetric if it's unilateral. And this is something that you always want to counsel parents about, because an in situ pinning is not going to improve that asymmetric gait. Diagnostic imaging to make this diagnosis includes x-ray, and then if you have a very high suspicion but your x-rays are normal, you could also consider an MRI to look for edema around the physis that may suggest a pre-slip. Classification is typically stable or unstable, and this is important because this is how we know how to prognosticate for the families. So a stable SCFE is one in which a child can still bear weight. An unstable SCFE is one in which they cannot, and the unstable SCFE has a much, much higher rate of going on to developing osteonecrosis. And so again, this helps you counsel the families about what to expect. Treatment in the immediate setting is protected weight bearing. Oftentimes, if they're in the office, you'll admit them to the hospital. And again, if you have any concerns about an atypical appearance, you may consider doing some endocrine testing or an endocrine consult. Surgical fixation and in situ pinning, I would say, remains the gold standard, with the caveat that if you're in a setting that has a sort of a hip team or a hip preservation team, or even an on-call roster for that, then probably in situ pinning would not be the best thing. And rather you would probably do a surgical hip dislocation. When you're thinking about fixation, things you want to consider, whether or not to prophylactically pin the contralateral side. A good rule of thumb I still use is if the triradiate cartilage is open, the number of screws to use. So typically we use 1 for stable and 2 for unstable, unless you simply can't get 2 in. Usually there's 6, 5, or 7 screws. If it is an acute unstable SCFE and presentation, you're going to think about also decompressing the capsule so that you don't tamponade the vessels and then inadvertently go on to AVN. And again, there is a role which is emerging for surgical dislocation. And this is just an example of in situ pinning and then contralateral fixation. We'll go on down to the knee. Again, you may get this in a trauma talk as well, but oftentimes, young athletes will present with acute injuries, which are fractures. And again, because of the relative weakness of the cartilaginous growth plate, oftentimes fractures are physeals or a Salter Harris. And this figure is showing you a review of the different Salter Harris types. So oftentimes a physeal fracture of the distal femur is a high energy injury from sports like football and soccer, or even a car accident. Oftentimes it's a direct blow, and occasionally it's a hyperextension mechanism. Kids will not be able to weight bear through this. The knee will be quite swollen, and they'll be usually discretely tender. Treatment depends upon the type of fracture and the amount of displacement. So an unstable, irreducible, or an articular fracture are the ones that undergo surgical fixation for sure. Ones that are extra-articular, reducible, or reduced, or minimally displaced and stable may potentially be treated in a long leg cast. I think at this point, we are no longer recommending stress views, although that was typically a tested thing. And I guess if there's really a question, you could do, again, an MRI. The pitfalls of this injury, I've listed them here, neurovascular injury and compartment syndrome. And then, again, one to really lay crepe with the families about early is growth arrest, because this is commonly associated with growth arrest. And as you know, this is the most rapidly growing physis in the body. And so this can result then in angular deformity and or limb length discrepancy. And so this is something that you have to follow over time. So moving intra-articularly, this is I would say a quintessential pediatric sports injury, although we do see tibial eminence fractures in adults. This occurs usually between the ages of 8 and 14. It's considered to be the equivalent of a mid-substance ACL tear. As you know, the tibial eminence is the insertion site for the ACL in the knee. The mechanism of injury is typically non-contact, again, a hyperextension direct blow to a flexed knee. Kids will give you that history of immediate onset of pain and swelling and hearing a pop at the time of injury. The knee will have an effusion and the child may limp. And then your physical exam tests for ACL or meniscus will be poorly tolerated. The classification system that we use for tibial eminence fractures is the Myers and McKeever classification, which I've listed here. So all the way on the left, the type 1 is not displaced. This may be treated with a long leg cast and some relative extension, so just a touch of flexion. Or you can also do a cylinder cast. So a type 2 is listed in B here. This is where you still have a posterior hinge in place. These may be treated non-operatively if you are able to effect a reduction, and that's typically by placing the leg into extension. And the next pictures will show this. Sometimes you can't get that reduced, and it's usually because there's something interposed. And an irreducible type 2 fracture is also one that we recommend undergo surgery. Type 3s are the completely displaced, and then the type 4s are either comminuted or rotated, and 3s and 4s, there's generally no question about a surgical indication for this. So again, we talked about long leg cast and relative extension, or arthroscopic versus open reduction with fixation. Our studies tell us that if you are the treating surgeon, you do what you are comfortable with, and be it arthroscopic or open. And if you do that, then there's no difference in outcomes. You always want to think about looking for associated injuries such as a meniscus tear. And then this, I think, probably is one of the more highly testable questions with the tibial spine, and that's that the soft tissues that may be interposed include the anterior horn of the medial meniscus, which is in the next slide, or the intermeniscal ligament, and that's what you're looking at here. And then also always to remember and to counsel patients as well that prior to the bony injury, the ACL itself undergoes plastic deformation, which is permanent. And so this knee may always feel looser. If you do KT1000 testing, it will be objectively looser than the unaffected knee, although this does not typically become a clinical concern. That said, there was a recent study that did demonstrate that kids who have a history of tibial eminence fracture are more likely to sustain an ACL injury later on than ones who have not. And this is just a slide of pictures to remember. On the left, you can see the anterior horn medial meniscus is entrapped within the fracture site. And then the one on the right is once the meniscus has been removed. And so this would have been certainly an irreducible fracture. And then once you remove it, you're able to reduce it. And this is now what that looks like. Here's just another example. This is a 7-year-old who underwent arthroscopic assisted reduction and internal fixation. You can see here an all epiphyseal screw was used. What we know about screw versus suture fixation is there doesn't seem to be a difference in terms of outcomes. We know that biomechanically 2 screws is actually worse than 1. This is because you can comminute what is potentially already a small fragment. We also know you cannot use screws in a fracture that is comminuted, and so that would be an absolute indication for suture fixation. If the fragment is large, either is an acceptable choice. And then in terms of removing hardware, about half of surgeons recommend it, but it's not required. And because it's in the notch and it's usually buried fully within the substance of the ACL, it doesn't typically become symptomatic. Okay, so moving on, this is the whole talk, actually, the ACL tear in the pediatric patient, but I'll just try to hit the highlights. You already know the anatomy. Again, historically, we used to think that a mid-substance ACL tear didn't occur in kids. We thought it was the tibial spine fracture instead. But now we know that there are increasing rates of both an ACL mid-substance injury as well as the surgical reconstruction to address it in the pediatric population. This has been demonstrated in the state of New York as well as nationwide. This is likely because of both increased awareness amongst surgeons and primary care sports medicine docs, and so we're probably making the diagnosis more. It also is likely reflective of a true increase in the number of injuries as a result of changing patterns of sport participation for kids. The history is one that you know, and the exam, again, usually you'll see a rapid onset of an effusion. You'll see surprisingly rapid onset of associated quadriceps atrophy. You're always going to want to do your clinical test for the ACL, and again, especially in a child, you're going to want to look at the other side because they are more likely to have an underlying laxity, which is physiologic. And then you're always going to look, again, for meniscal injuries and collateral injuries and posterolateral corner injuries. In a kid, you're going to look at their limb alignment. You can look at their, as well as alignment as well as length. And then you can do Tanner staging as well, and that will help you get a sense of where they are physiologically, how much growth is remaining, and this in turn will drive your treatment choice. We'll always get 4 radiographs of the knee because an effusion, a traumatic effusion in a kid of the knee is never normal. It's always going to be an osteochondral fracture, patellar dislocation, an ACL tear, meniscus tear, one of these things, but it's not always the ACL, and so we always start with radiographs. This also will give us a sense of what the growth plates look like. Again, if you have a high suspicion for an ACL tear, you're probably going to do a limb alignment film. I also call these a 3-joint standing film. It's a hip to knee or a hip to ankle X-ray. This is just so you have a preoperative knowledge of whether they're, asymmetric already, but varus or valgus, or if they have an existing limb length discrepancy. And then you'll do an MRI to look at the ACL, the meniscus, the cartilage, and again, this can be helpful for assessing physeal patency. Initial management is always to reduce pain and swelling and restore normal motion. So most of the time we will send kids to prehab in order to achieve these goals, as well as to regain muscular strength. I always tell kids, the stronger they are going into surgery, the easier it will be for them to rehab and recover from it. And then probably most important, we want to prevent additional instability episodes by activity restriction and a hinged knee brace. And this is because we know that the more instability episodes that a child sustains prior to the ACL reconstruction surgery, the more likely they are to have concomitant injuries of the cartilage and the meniscus, and the more likely these are then not only to be present, but to be severe and perhaps even irreparable. So historically, a child who presented with a mid-substance ACL tear was told to modify activities until their growth plates had closed and they could undergo a typical adult-type ACL reconstruction, but the natural history of these sort of rehab knees is poor. And so now that the gold standard of care for a child with an ACL tear is timely surgical reconstruction. We're always going to use autograft in a kid because we know that the rate of re-tear is 4 times higher with allograft than autograft in a child. And then depending again on your assessment of their physeal status and their physiologic status, you're going to consider doing maybe a physeal sparing technique or a physeal respecting technique rather than a traditional adult type technique. And so these pictures are showing on the left, this is just a sagittal MRI of a mid-substance ACL tear in a skeletally immature knee. And then on the right is a schematic drawing of the iliotibial band extra-articular ACL reconstruction. So this is a physeal sparing surgery. And just in brief, you harvest the central third of the iliotibial band, you leave it attached distally at Gertie's tubercle, you dissect it free proximally, you affix it with sutures to the lateral periosteum, you pass it through the over-the-top position through the knee under arthroscopic guidance, you pass it under the intermeniscal ligament in the front, and then you affix it medial to the tubercle to underneath the periosteum on the proximal tibia. Again, medial to the tubercle and distal to the proximal tibial physis. This is an example of a different type of physeal sparing ACL reconstruction. This is one in which tunnels are drilled. That's in contradistinction to the IT band, but the tunnels are all epiphyseal here and here, rather than your traditional transphyseal tunnel. And I'll just make a comment about the outcomes of ACL reconstruction in children. So in general, the biggest risks and the things you always want to prepare kids for, one is they have very high risk of re-tear at upwards of actually like 15 to 20%. I usually quote them that about 10% of the time, it's the ipsilateral knee, and so they've sustained a tear of the graft. About 10% of the time, it's the contralateral ACL, and then there's an additional 10% risk of returning to the operating room in the first 2 years for treatment of a torn or retorn meniscus. So re-tear or contralateral ACL tear are both complications that occur with some frequency after ACL reconstruction in kids. Arthrofibrosis is also described at a rate of about 8.3%. And then if you use a technique like the one that you're looking at here, even though this is technically physeal sparing, you can still get iatrogenic thermal injury to the physes, or certainly a transphyseal technique can cause injury to the physis, and this can result in premature closure and then resultant angular deformity and or limb length discrepancy. Typically it's going to be an angular deformity, and it's typically going to be a distal femoral valgus or a proximal tibial recurvatum, because you can inadvertently close the apophysis as well. All right. Meniscus tears in kids are very rarely an isolated injury. Typically they're seen in conjunction with an ACL injury or in the setting of a discoid meniscus. And so in fact, most isolated lateral meniscal injuries in kids under 14 are a discoid meniscus, unless proven otherwise. And so typically they'll present with pain, effusion, and joint line tenderness in the setting of a non-contact pivoting injury, and you can do your McMurray's. Your thessaly, your test of choice. MRI is diagnostic for meniscus tear typically, and kids were almost always going to try to surgically repair them. Always, always, always. And if they are truly irreparable, then partial meniscectomy or removal of the tear itself. And then I typically do some kind of some kind of bone marrow stimulation procedure like a microfracture of the notch to try to improve the biologic healing environment. This is just an example of a bucket handle tear. So you can see that it is torn and displaced. You can see this on the sagittal MRI, that there's a blunting of the posterior horn, and then you can actually see the posterior horn has been translated into the anteriorly. On that MRI, this is what it looks like inside the knee. And then this child got reduction in fixation. I'll just make a quick comment about different types of fixation, or different techniques. So this child got a hybrid. You can see in the back here, this was all inside. That's fast fix is an example of that. Here, this was inside out, an inside out technique. Usually we do that in the mid body. I use that using the zone specific cannulas. And then in the anterior horn, typically we'll do an outside-in kind of repair. Let's talk about the discoid meniscus, which I've already sort of mentioned. But so it's almost always the lateral meniscus, although a handful of times a medial discoid meniscus has been reported in the literature. This is an anatomic variant. It is more prone to tearing. So it's more prone to tearing because of its abnormal histology. So it's not only abnormal because it's a disc rather than a C, and then sometimes you can actually get the block-like where it's extra thick as well. But so its macromorphology is abnormal, but also its micromorphology is abnormal. It's not put together correctly, and so it doesn't withstand the hoop stresses the way it's supposed to. And lastly, the typical peripheral attachments may be missing, and so it's an abnormal shape. It's more prone to tearing, and then it's more prone to being unstable. And those are the three things that you want to address at the time of surgery. Discoid meniscus has a variable presentation, so it's the youngest kids will come in typically with a knee that's not painful, but they'll have a palpable clunk when you bring the knee into extension. This is typically called the snapping knee syndrome. And so the history of this, a parent might say, well, intermittently they limp and complain of pain for a day or two, and then it is self-limited. And oftentimes this has happened several times. This is in contrast to the older child or adolescent who may come in with just symptoms of a frank meniscus tear, the pain catching and locking. And treatment is surgical for those patients who are symptomatic. And so again, addressing those three things, typically we'll start with a saucerization, in which we remove the redundant central tissue with the goal of leaving a 6 to 8 millimeter peripheral rim. And then if within that there remain tears, and oftentimes there are complex or certainly at least horizontal cleavage tears, but we'll address those residual tears with repair. And then lastly, we'll assess the peripheral rim, remembering that the lateral meniscus is more mobile normally than the medial meniscus, but oftentimes there will be abnormal or pathologic mobility, and in those instances we will also stabilize the peripheral rim, and this is done with stitches. These are just two examples of discoid meniscus. This is I would say a partial, untorn, stable discoid meniscus. I think you could argue that this actually wasn't even causing symptoms, but but rather could even have just been, found at the time of surgery for something else. But regardless, got a saucerization. And then this is a 3-year-old. Actually, this is done through a wrist scope, who has instead that very, very thick, complete discoid meniscus that, at least fortunately, was peripherally stable. And so this child presented with intermittent but symptomatic snapping episodes. All right, moving on to osteochondritis dissecans, or OCD of the knee. This is we don't really understand, and so it's idiopathic. We think it's related to overuse because we tend to see it in kids who are particularly active, and we think it's related to a watershed area of the knee. And the blood supply becomes affected. The lesion involves the articular cartilage as well as the underlying subchondral bone. You can see here, this is an MRI demonstrating this. It's not listed here, but we'll always get 4 views of the knee when we're evaluating it in kids, and it's the notch or tunnel view that is the one that will typically identify your OCD lesion because they tend to be posterior. Kids may come in with nonspecific knee pain. It's oftentimes activity related. They may have intermittent swelling, locking, and catching. You may note an effusion or atrophy of the quadriceps, and they may be point tender over the affected area. And then there are some provocative maneuvers you can do as well. Oftentimes, if it's gotten to this point, though, then it's existed for a while, and that's part of the problem is that these are minimally symptomatic until they become actually quite problematic. Treatment for OCD is lesion dependent, and so what this means is that for small lesions that are stable radiographically and at the time of diagnostic arthroscopy, especially in patients who have open physes, may be treated successfully, oftentimes even without surgery. So small, stable, then radiographically or on MRI with open physes. And so a nice way to remember this is the rule of 12. So basically kids under 12 with patent physes, lesions that are smaller, so under 12 millimeters, and those that have not had symptoms for more than 12 weeks are the ones who are most likely to respond to non-operative treatment. Larger lesions, unstable lesions, and a child who is skeletally mature are less likely to heal without surgery and are more likely to require it. And then when we're talking about stable versus unstable, this again is an MRI diagnosis as well as an arthroscopic diagnosis. But on MRI, you may see cystic changes behind the lesion, you may see fluid tracking behind the lesion, and you may see actually frank cracking of the articular cartilage surface. For those who may be candidates for non-surgical treatment, initially we'll do immobilization, non-weight bearing, and activity modification. The trials that have looked at casting versus bracing versus nothing have not really demonstrated one to be superior to the others, but really you're going to do protected weight bearing and modify their activities. And so, this is one of the least fun diagnoses to make in a kid because really you're going to pull them out of sports for at least 3 months, and then you can't guarantee that it will heal. For those lesions who are those lesions which are frankly unstable at the time of presentation or fail to respond to non-operative treatment, we do recommend surgery. And then surgery is also tailored to the lesion itself. So again, at the time of diagnostic arthroscopy, if you find the lesion to be stable, then it can be drilled, and this can be done in either retrograde or anterograde. Usually I'll use a 4-5 C wire or K-wire. Lesions that for which there is a concern that it is unstable will undergo typically in situ fixation, and this can be done, it's usually done with a screw that is buried, a compression screw that's buried, headless and buried beneath the cartilaginous surface, and these can be biocomposite or metal. Metal, we typically will take them out, and so oftentimes you'll have to go back. The biocomposite have their own problems. They can actually cause more of a reaction inside the knee, and they can break. And so neither implant is perfect. And then for lesions which can't be salvaged, you can consider, which are under 10 millimeters in diameter, you can do an autograft transfer. And then for ones that are not salvageable and too large for an autograft transfer, you can do an allograft. Next, we'll talk about just briefly patellar instability. So this is very common in kids. It's typically acute, oftentimes traumatic, although not always. It may be sports related, it may not. The mechanism is usually, when it's indirect, the foot is planted, the knee is flexed, and then a valgus internal rotation moment is applied. It can also be a direct blow, like a tackle with football. The knee may feel unstable, or they may tell you they dislocated their knee, and you'll note usually a large hemarthrosis right away. The immediate treatment is what we do for most sports injuries, and then the ones that go on to surgery, and this is an example of that, are the ones that have an osteochondral fracture. So this is an example of a large osteochondral fracture, in which the donor site is the patella, and you can see that on the right. The piece is removed and then put back into place. And then this is what it looks like. I closed up the capsule and put the scope back in. I will tell you, I've changed my practice since this case, and so now in addition to fixing the osteochondral fragments, in the acute setting, I will typically add an MPFL reconstruction. And this is because of a study actually also that came out of Rady Children's, just demonstrating that the risk of redislocation after surgery for an osteochondral fragment in the setting of patellar instability is very, very high. And so because of that, I will add the MPFL reconstruction. Surgical treatment for patellar instability, I think indications, if aside from an osteochondral fracture, would be recurrence, because we know once it happens a couple of times it's going to continue to happen, and then the ones for whom multiple instances of instability have occurred are more likely to go on to have some arthritis. And then the stabilization of choice depends on the factors that contribute to it, as well as on the physeal status. And so, risk factors for patellar instability are femoral anteversion, patella alta, external tibial torsion, generalized ligamentous laxity, trochlear dysplasia, and increased TTTG. And so you sort of look at the constellation of, and valgus of the knee. And so you look at the constellation of reasons why an individual child might be at risk for recurrence and address it as such. So in addition to an MPFL reconstruction, which can be done in a skeletally immature patient, you may also consider in an older child with an increased TTTG adding a TTO. You're not going to be able to do that obviously in a child who has open growth plates, but then for that child you may think about, well, is there a lot of valgus and could I do guided growth to correct that? MPFL reconstruction. And then there are also various procedures that have been described that are non-anatomic, that are all soft tissue to try to temporize patellar instability in children who are skeletally immature. This is probably the thing that is the most common pediatric sports injury that we see, Osgood-Schlatter's disease. It's the traction apophysitis of the tubercle where the patellar tendon inserts, and so it affects the extensor mechanism. The repetitive traction in the tuberosity results in sort of micro stress fractures, and the body's response to this is to try to build more bone, almost analogous to arthritis, or I sometimes wonder if it's analogous to the CAM lesion that we see in FAI. But that's why we see that bump form. It occurs typically in 10 to 15-year-olds. 15 is a little bit old, but typically in that age group, especially in those running, jumping, things like soccer. More common in males. Oftentimes you will elicit a history of a recent growth spurt. They'll have pain during and sometimes even after activity. On exam, they'll have pain with passive knee flexion and with active knee extension, and you'll note that their quadriceps are oftentimes very tight, and they'll be tender directly over the tuberosity. We typically don't need an X-ray to make this diagnosis, but when one is done, you may see abnormalities of the apophysis. Again, which you can see on this X-ray, but again, oftentimes not needed. Usually we'll do activity modification therapy. Sometimes we'll add a strap, that show pad strap. Symptoms improve after the growth plate closes. And so I usually counsel patients that the most common sequelae is sometimes they'll continue to have some pain with kneeling, like in the garden, for example. For very refractory cases of pain, you can do an ostical resection. I've only ever indicated this one time, so it's almost never needed. And then we're almost done, but I just wanted to mention, so Osgood-Schlatter's again is extremely common, and then it's analogous injuries throughout the body are things like Seaver's disease in the heel, the calcaneal apophysis, Iceland's disease, the base of the fifth metatarsal, little leaguer's elbow, the medial epicondyle. So all of those are apophysitis. Inflammation episodes. Usually the way I think about it with patients is that this is not a dangerous pain. We usually try to treat the symptoms of pain. Usually there's, again, associated tightness, and so we can work on physical therapy, or maybe we work on throwing mechanics, for example, in a pitcher. And then although Usually this is something that I will let kids play through as long as they're not limping and it's not interfering with sleep or ADLs or school. Every once in a while, the prodrome of apophysitis can then go on to the apophyseal avulsion fracture, just like saw in the hip. And so the tibial tubercle avulsion fracture is listed here. This again occurs in adolescence, usually at the end of skeletal growth. Again, in jumping sports, they'll come in unable to weight bear, telling you that they had the acute onset of pain, swelling, and deformity, usually while going up or down actually from a rebound. You'll note the knee is usually typically very swollen. The compartments may be full, and the extensor mechanism will be disrupted. They won't be actively able to extend it. The x-rays are diagnostic. And again, I just mentioned the prodrome of Osgood-Schlatter symptoms may actually precede the femoral avulsion event. And so treatment depends upon the degree of displacement and whether or not it's intra-articular. So minimally displaced fractures can be treated with a long leg cast and extension, and then fractures that are displaced or intra-articular will require typically open reduction internal fixation. And then to me, the probably highly testable questions here are, this one is a risk factor for compartment syndrome, and it's the anterior recurrent tibial artery. And then also, you never want to miss, this is an example of a kid actually who, I'll say a couple things about this kid. We put the bone back perfectly, but there was nothing attached to it, and that's why you see the suture anchor, because he'd also avulsed the patellar ligament right off the bone anteriorly. And so if we had just fixed the bone, we would not have restored the extensor mechanism, as well as, fixing the fracture intra-articularly. But also, when you're in the operating room, you're always getting your x-rays of the knee laterally, and you're always worried that you have patella alta. And so I think a nice trick is to take an x-ray of the contralateral knee before you even scrub or drape. So then you know what that child's normal is in terms of patellar height with the knee in extended position. And this child was particularly ligamentously lax, and you can see the hyperextension of the knee. All right, so in conclusion, young athletes have unique musculoskeletal injuries due to the presence and relative weakness of the cartilaginous growth plate, and these can be acute, like a Salter-Harris fracture, or an apophyseal avulsion fracture, or they can be more chronic, like osteochondritis dissecans or apophysitis. My typical treatment approach is it safe or unsafe to let them continue to play? Are they going to make a problem worse or cause a problem, a long-term problem? Certainly, if they're unable to bear weight, or you see a limp, or you see swelling of the joint, or any atrophy of the quads, or weakness, then this is one that you're going to want to investigate more. You're going to start with radiographs of the affected area, as well as typically, for example, if it's the knee, you typically will do radiographs of the hip as well, and vice versa. And then, with additional concern, you can do additional imaging, be it MRI or CT. We try to minimize CAT scan in kids, especially, as you know, because of the associated radiation. And then lastly, always remember that the hip and knee are connected, and that's, again, just speaking to the SCFE. And so with that, I will thank you and wish you guys good luck.